Thank you, Mr. Dobbin, and can I too congratulate the Honourable Member for Scunthorpe for calling this debate on tuberculosis, a disease which 8.6 million people catch every year and 1.3 million people die of. It's a huge issue, and like many other members, I was fortunate enough last year to join a delegation from Results UK to Zambia. During that delegation, we were looking at the link between HIV and TB, but one of the places we did visit was Lusaka Central Prison. Now, Mr. Dobbin, I don't know if you've ever been to a prison in Central Africa before, but just a couple of months before we attended, the Vice President of Zambia, Guy Scott, had visited another prison and described it as hell on earth. And I must say, I've never been anywhere like Lusaka Central Prison. It was absolutely shocking. It was a prison that was built by the colonial authorities in the 1920s to house between 180 and 200 prisoners. Now it houses almost 2,000. We're taking to cells that were no bigger than my bedroom at home, initially designed to sleep between 6 and 10 people, and now between 80 and 100 prisoners are locked in these rooms for up to 14 hours a day. Now, I looked at this room and I thought, how on earth do they even fit that many people in? And apparently the way they sleep is they line up 12 people against the wall, who then crouch down with their back to the wall, sit down, open their legs, and the next 10 or 12 people come and lie between their legs, open their own legs, and then the next 10 or 12 people to really cram them into every single space in this prison cell. There was a complete lack of mattresses and blankets. The toilet facilities were just nowhere adequate for the number of prisoners who were in the prison. There was an open drain or sewer which ran through the middle of the courtyard that contained some disgusting-looking brown liquid. There was a lack of medical facilities. There was no health clinic on the prison site, and there was a lack of medicine for sick prisoners. And there was a lack of food. There was only one basic meal a day, which was completely lacking in protein. I think it's fair to say that the conditions in the prison were not conducive to general health. Catching TB should not be part of a prisoner's prison sentence, but in this prison it was. At one stage, TB infection rate was almost 100%. TB is one of the fastest growing epidemics in prison populations in sub-Saharan Africa, and it doesn't just present a threat to the inmates, it presents a threat to the wider population as well, because these prisons are acting as a reservoir for TB, and they get into the wider community through staff visits, through visitors, and through inadequately treated former prisoners when they're left. TB does not respect prison walls. But there was a bit of a bright spot about the visit to our prison, because we're taken there by the Commissioner for Prisons for Zambia, who was actually very, very open and very keen for us to see the real situation in the prison. We were also shown, and we've heard several other members mention TB Reach before, a TB Reach project which had been set up in the prison along with the Centre for Infectious Diseases Research in Zambia. Within that TB Reach programme, they were doing TB and HIV screening, they were delivering treatment, they'd introduced isolation cells for prisoners with multiple drug-resistant TB, and they'd organised a prisoners' drama group, teaching prisoners to look for the signs of TB, to understand the importance of taking their treatment, and the importance of making sure that if they do catch TB, to make sure that they make people aware of it and actually get the treatment that they then require. And they had seen some massively successful results. The TB infection rate was down to 30%. Now that's still huge, but it's awfully lot better than it had been a year previously. Early diagnosis and treatment is essential for controlling TB. And as we saw when we were in Zambia, TB Reach is pretty much the only mechanism which is designed to target and to treat the 3 million missing TB victims that we've heard about today. And one of the advantages of TB Reach is it's able to react very, very quickly. It can provide fast-track funding for projects to get them up and running very quickly, often within 6 months. And it's also willing to fund new and innovative approaches, which is important because organisations like the Global Fund will only fund projects that have been proven to be successful. They won't finance new ideas. They won't do experimental things to see if it will work. They will only fund ideas that have previously been proven to be successful. And we do need to find new approaches, because many of the places we visited in Zambia, whether they were clinics or hospitals or local community groups, they're in really isolated communities. And there is a need for new mobile technology. And we do need to start rolling out new diagnostic tests, etc., which can only be done if they've been tested, if the experiment's been done, and if there's an organisation like TB Reach willing to fund it actually on the ground. And we saw that in action when we visited Kanyama Clinic, which was a project run by the Zambia AIDS-related TB project, Zambart. And like my honourable friend, the member for Mid Dorset and North Pool, we saw the Gene Expert machine in action as well. Now, for those of you who don't know what the Gene Expert machine is, from the website it describes it as the Gene Expert system automates and integrates sample preparation, nucleic acid amplification and detection of the target sequence in simple or complex samples using real-time polymerase chain reaction, Mr. Dobbin. In basic terms, it's a diagnostic tool that can diagnose TB a lot more accurately than using a microscope. And it produces results much quicker too, often within 2 hours. And it can also detect TB in patients who are HIV positive. And of course, that's got massive advantages in some of these clinic locations out in rural areas, because people, when they go to the clinic, can have the test and can have the result whilst they wait. And one of the things that they were doing at this Kanyama clinic was encouraging local people from the community to get engaged, get involved as volunteers, and to help people, talk them through the process, and when they have got the test results, talk them through what that actually means, what the treatment will entail, and then when they go home, go out into the communities and make sure that they keep taking the treatment in the weeks ahead. It's the techniques and the machines that we saw, the Gene Expert machine, it works very, very well in some environments, but it's not perfect. And it can be very difficult in very isolated rural areas because it does require a constant electricity supply. So whilst we're out there, we're also looking at how alternative energy supplies, whether it's solar power, etc., can be used to power equipment, medical equipment, in rural areas. On our visit to Kanyama Clinic and to Lusaka Central Prison, we saw firsthand how TB Reach projects were having a real effect on the ground to improve TB diagnosis and to provide fast treatment. But as we've heard from my right honourable friend for Arundel and South Downs, the TB Reach project is time limited and new funding is now required now that the TB Reach grant is coming to an end. And there's also real concern about how some of these projects can be integrated into the national healthcare systems. TB Reach grants are for a short period of time, getting a new technique in use in a local area. But then if you want that to be a permanent solution, you need it either integrated into the national health scheme, you need it so it's in a position where it can be funded by the Global Fund, or you need it to be in a position where donor countries are willing to support it at the end of the TB Reach project. As we've heard today, the majority of the TB burden is concentrated in countries that often receive less donor funding. And whether it's drug-resistant TB in Eastern Europe, whether it's TB in prisons in Zambia, or the enormous scale of the epidemic in India, domestic governments must now start to step up to their own response to the epidemic. But the UK also has a unique opportunity to use its global leadership position to call on domestic governments to increase their own investments in the fight against TB, especially given our strong links to Southern Africa and India, who do account for the greatest part of the missing 3 million people who are missed by their health systems. TB is a global disease where the UK can have a real impact. Now, the Minister and Duffield have done a fantastic job making Britain a world leader in the battle against malaria. The UK government should also use its position to become a global leader in the fight against TB, a disease which is also one of the top infectious disease killers and for which global political commitment has so far been missing.
Thank you.